Gentleman, 71 years of age, normal body size. He got a history of atrial hypertension, atrial fibrillation, and recurrent GI bleeding on DOAC. His CHA2DS score is 3 and has blood score 3. Next slide. He got slightly anemic. Renal function is normal. Echocardiography showed normal left ventricular ejection fraction. His left ventricle is severely dilated. Next slide. And as we just discussed, we are doing CT scanning of all our cases before left atrial appendage closure, and you can see, first of all, it's giving what kind of morphology. This is a kind of a chicken wing, although you see that very distal part is like reverse chicken wing, but it's a combination of that. But I think the main body of the left atrial appendage is like a windsock, which we're going to close. Next slide. We used it for measuring the ostium because we want to see where the device is going to sit here, and you can see that we got a maximum diameter of 26.7 millimeter, minimum diameter of 23.8, and also a perimeter-derived diameter of 24.9 millimeter. Next slide. And we just heard about this materialized. Again, you can have this center line through all the left atrial appendage. That's the blue one. And you can see that you have the yellow one is the minimum diameter at each position, and the red one is the maximum. And where we predict to have the device in place just behind the circumflex artery, that's the blue box you see on the left-hand side, you see that it's going to fit with a Watchman Flex 27 millimeter to have the optimal implantation. Next slide. We can also use a CT scan for where to puncture it. You know, normally you would go inferior, posterior for left atrial appendage closure, but in this specific case, we're going to have a more coaxial alignment with the delivery sheet. If you still go inferior, but instead of going posterior, stay in the center of the septum. Next slide. And also the CT scan can be used to have the decision from where to place your C-arm, and you can see if the C-arm is in a RAO 30, cranial 3 degrees, we're going to be perpendicular to the landing zone. So this is where we're going to do the implantation. Next slide. We have done computer modeling here, trying to look at different sizes. Watchman Flex at 24 millimeter, you see here it's giving too little compression, only 6%. Next slide. Whereas the 27 is going to give us a better compression. And I think if you also look how it's going to sit, probably the one on the left side with a 30% compression is going to have a better projection inside the left atrial appendage compared to the other one where it's sticking a little bit out in the chicken wing. Next slide. If you even upsize it to a 31, you see it's going to stick out. You're going to have too much shoulder. So that's the reason why we're going for a 27 millimeter device with a more vertical implantation. So next slide. So this is the plan. The patient is in local anesthesia, fully awake. It's going to be guided by eyes. We're going to do the transeptal puncture with the worse across sheet. I'm going to show that in a minute. And we're going to use a double curve true seal delivery sheet and a Watchman Flex 27 millimeter device. So Ole, maybe you can tell us what you have done so far.
Yes, we didn't do that much so far. So we did 2 echo-guided venous punctures. One on the left-hand side for the eyes, that's now a 10 French sheet in. Then we just have a 6 French sheet in the right femoral vein. And we have an arterial axis radial for pressure measurements, invasive, otherwise we don't have any. And also we have a pigtail in the aorta.
You like to have a pigtail in the aorta group, just yeah. Explain why.
I like it to, well, if you do the eyes-assisted transeptal puncture, give you an extra reference of where the aorta is, and also sometimes we do fusion imaging of the CT images on the fluoro, then it works as our calibration actually.
Yeah. And in a minute we're going to do the transeptal puncture. So just explain us what is this system, because it's different from what most people are doing nowadays.
Yeah, this is that VersaCross set, so that exists out of 2 pieces, components. You have the sheet and you have the wire, and that's all you need. The sheet comes out of the box less shaped, so this you can shape manually with your just by your finger. I like typically a 90 degrees, a rather large curve for the puncture in these patients with atrial fibrillation and large atria. But the first step to do is to introduce this wire. Yeah.
And the wire is pre-shaped, so you can
Yeah.
you don't need to change it. So you use the wire for the perforation, and afterwards you can place it in the left atrial,
Yeah.
the left atrium, and then you can use it to cross not only with that sheet but also with the delivery sheet.
Yes, because the body of the wire is stiff enough to even support to bring in delivery sheets up to 14 French.
Yeah, and
even more.
and you cross it by RF energy.
Yeah.
Yeah. Okay. Yeah. So why don't you introduce it, and maybe in the meantime we can go to you, Niels, and you can tell us what you see on ice.
Yeah, in the ice procedure we now put the transducer in the right atrium, looking up the end that is up here, and looking at the septum, and here's the transeptal needle. Before we did this, we also checked that there's no thrombus in the appendix by going up into the pulmonary artery and checking that the appendage is clear of thrombus, and you see here that there's no thrombus in the appendage. We also checked that there's no pericardial effusion, so we can make sure that we can check afterwards whether there has been a puncture. So we have checked the pericardium before the procedure.
So if you go back to this view, Niels,
Yeah.
for people who's not used to looking at ice, just what are you looking? What is up and down here?
On this image you can see this is the SVC coming down. This is the fat part of the septum. Here's the thin part where we want to do the puncture, and this is the inferior part of the septum. And at one point we will be interested in knowing whether we are anterior and posterior, and that's where I will manipulate the catheter to get the aorta anterior, so that this is now anterior part of the septum, posterior part of the septum, and we want the puncture to be here in the middle of the septum.
Yeah, that's correct. And one thing which is a little bit challenging here is that the patient actually got a PFO. So we need to be careful we don't cross it at the PFO, because it's going to give us a suboptimal coaxial alignment. So yeah.
Yeah. Okay, so maybe now on the fluoro you see that Versa cross wire that's first introduced to that 6 French sheet. You see it curves already, and that typically takes very nice trajectory up to the vena cava superior, and then now this is that Versa cross sheet that's brought onto it, and now it's a matter of just pulling back the wire just into.
So you have the sheet, the dilate, and the wire. So there's no needle here.
Yeah, no. Yeah. So now, on the other hand, I keep the same rule. I go here to 4-5 o'clock. Okay, Niels, ready to come down? I'm coming down slowly. Keep my needle around.
So in a second you see it's coming down from the SVC. It's riding on septum secundum, and in a second it will fall into the fossa down to the septum primum like this. And now again we need to make sure that we're not.
I don't see tenting yet, so
yeah, we should not go into the PFO. We need to go more inferior.
So Niels,
Still
can
superior.
you hear me? Niels?
yeah.
Can you hear?
Yes.
Yeah. So you're an imager,
I can
right?
hear you.
Is this
Yeah.
is this what you used to do in Copenhagen and Rigshospitalet? That
Yes.
imager is manipulating and controlling the ice catheter?
Yeah, that's what we've found has been a good idea. So you can focus on this particular modality and get the optimal images. So we have also one person for these complex procedures to do this.
Yeah.
So now you're in
But
the
so the